Hello, my name is Ann Brazo. I'm the founder of MPN Advocacy and Education International. Today, we are having another conversation with an MPN specialist, and this time it is Dr. Andrew Srisuwananukorn from Ohio State University, a new father, I will add. Congratulations. And he's going to be speaking with us about myelofibrosis and pre-fibrotic MF, which is a fascinating subject and something we are all interested in. And he's going to share some slides and speak with you, and then we'll go to questions. So when you have questions, please send them our way, and we will get to those soon. Thank you for joining us, Andrew.
Great. No, thank you so much, Anne, for inviting me to speak with you all today. Are you able to see my slides? Is it visible to you all?
Yes.
Okay, perfect. Again, my name is Andrew Srisuwananukorn, and I'm one of the MPN specialists at The Ohio State University, leading a number of clinical trials in myelofibrosis and including prefibrotic myelofibrosis. And separately, I do a lot of artificial intelligence research, primarily for decision making in MPNs as well, too. So, today I'm happy to talk to you about prefibrotic myelofibrosis. I over-prepared, so I'm actually going to skip a lot of these slides, and I'm happy to answer any questions in the end. Here are my disclosures, and my main disclosure, as Ann said, is that I'm a new father. I'm just coming off of paternity leave, so if I say something confusing, I am quite sleep deprived, so please give me some grace and patience. So, I think that I won't go over number one. I should talk about essential thrombocythemia and primary myelofibrosis because critically understanding these two diseases will help us understand kind of the landscape and the history of prefibrotic myelofibrosis. And I'll finally touch upon a little bit about what we're doing at Ohio State University. So, given that this is the MPN advocacy group and education group, I will skip this section about biology and epidemiology. Give me 1 second, and then I will just go straight to essential thrombocythemia. So the reason why I have to talk about kind of the basics of ET, and maybe it makes sense to go over a patient presentation. So here is a real patient of mine, 40-year-old with history of hypertension, uncontrolled headaches, with a complete blood count showing a normal hemoglobin and a normal white blood cell count, but a very high platelet count at 1.3 million. This patient has high platelets for the past 3 years, and upon further analysis, when the patient came to see me, we found that they had a calreticulin mutation. And thankfully, when we did a stat MRI, he did not have a cerebral venous sinus thrombosis or a hemorrhage. It was just some type of other headache. In the clinical presentation of essential thrombocythemia, 50% of these patients are asymptomatic or incidentally found when they had routine blood work from a primary care doctor. But otherwise, those that are symptomatic can have vague symptoms, including disease-related symptoms such as headaches, dizziness, fatigue, or symptoms related to complications of essential thrombocythemia, such as thrombosis or bleeding or pregnancy loss as well, too. So when we risk stratify patients in essential thrombocythemia, one thing that we really worry about, we do worry about progression to myelofibrosis and acute leukemia, but we worry more about their thrombotic risk. And we know, based off the literature prior, that these patients can be stratified into low risk and high risk for acquiring blood clots in their legs with deep vein thromboses, in their lungs with pulmonary emboli, with stroke, or heart attacks with cardiovascular events. We can quickly see that patients are low risk if they're age less than 60 years old and no history of thrombosis, as can be seen by above this red line, or high risk for acquiring another thrombosis or cardiac event for patients that are elderly over 60 years old and have a history of thrombosis prior. Now, this leads to a lot of decision making in essential thrombocythemia about how I particularly treat ET patients is a very simplified manner. Most patients that have essential thrombocythemia are given aspirin to prevent cardiac events. Those that are low risk for acquiring a thrombus, including the younger patients, they're just observed. And those that are high risk, including those that had a previous thrombosis, they're given frontline therapy with either hydroxyurea or some formulary of peginterferon. Now, the goal here in essential thrombocythemia, or ET, is to prevent future thromboses. Now, I'll touch a little bit upon these two agents, hydroxyurea and the interferons. The truth is, the frontline treatment for ET is quite controversial between these two. I use both of them all the time, and I have no qualms prescribing either. But general advantages and disadvantages include the fact that hydroxyurea is readily available, very affordable, daily dosing as an oral therapy, and generally well tolerated. There's some data to say that the bone marrow biopsy does go into remission more so with hydroxyurea compared to the interferons. And the interferons, there are two main formularies, peginterferon alpha 2A and ropeginterferon alpha 2B. These are proprietary, they're expensive, they're not generic. They're off-label right now, although that may be changing with the ropeg formulary in the future. They're weekly or biweekly dosing. They're not daily, and they're injections. They're not oral therapies. They tend to have a higher side effect profile, but they potentially could be disease modifying, which are why these agents are quite enticing to use in ET. And that's really all I'm going to say about ET. And we'll move on to myelofibrosis prior to talking about the meat of today of prefibrotic myelofibrosis. So patients with overt, very obvious myelofibrosis, these patients are very symptomatic. And here's another case presentation with a patient with a JAK2 V617F mutation with polycythemia vera for many, many years. But instead of having a high hemoglobin, the patient has, a lot of like night sweats, weight loss, abdominal pain. Their spleen can be palpated on exam at 20 centimeters below the left costal margin. Their complete blood count, as I mentioned before, no longer do they have polycythemia. They have anemia with a hemoglobin of 9.9, normal white blood cell, and a low platelet count. Upon a bone marrow biopsy, this patient may have post-polycythemia vera myelofibrosis. Now, in contrast to ET patients, these patients have quite a lot of symptoms that's typically due to the ongoing inflammation that is the hallmark of myelofibrosis. These patients may have enlarged livers or enlarged spleens due to ineffective hematopoiesis, or where their bone marrow is not working very well. Their blood is actually being made in their spleen, and therefore their spleen becomes quite large. They may have symptomatic splenomegaly. There could be impaired blood cell production with cytopenias, and the constitutional symptoms is driven by the inflammation. So these patients have night sweats, fatigue, bone pain, etc. Now, the treatment regimen for overt myelofibrosis has excitingly changed in the past decade with the advent of now 4 what we call JAK inhibitors: ruxolitinib, fedratinib, pacritinib, and momelotinib. So we're very lucky in the era of new therapies in myelofibrosis where we can choose which therapies would be helpful for certain patients. Now, it's an entire another lecture to go over exactly how I choose which JAK inhibitor for which patient, but the point of this slide is to show you that the majority of these JAK inhibitors, number one, inhibit this very important protein called JAK2, but number two, they have a side benefit or a side effect profile that has a little bit of a different flavor for each of these JAK inhibitors. To the point, ruxolitinib is used in front line for the majority of the time. Fedratinib is typically used in second line when ruxolitinib is not effective anymore. Pacritinib is very helpful for patients with platelets less than 50,000, and momelotinib is very helpful for patients that are anemic. That's a very simplified version of how to choose JAK inhibitors. Now, the goal for myelofibrosis, though, as opposed to thrombotic risk, is to alleviate symptoms, alleviate the inflammation that's going on in myelofibrosis, and reduce splenomegaly. We unfortunately do not have agents to act as disease modification tools. So the point of the JAK inhibitors is to alleviate symptoms, at least in 2025. It's a little bit more nuanced than that. We do use risk stratification systems in myelofibrosis to make some very large decisions. There are many risk stratification systems in myelofibrosis, and that's out of the scope of today. But in a nutshell, those that are quote unquote lower risk by any of these systems, sometimes they're asymptomatic and we do nothing more than just observe them and then follow their CBCs. We may, for the symptomatic patients, start one of the JAK inhibitors, and selected patients, we may refer them to an allogeneic stem cell transplantation. Those patients with higher risk for progression to acute leukemia or blast phase MPN, those are definitely the patients that we refer up front for an allogeneic stem cell transplantation, and we consider highly the JAK inhibitors to optimize them for stem cell transplantation. So the takeaways there for ET and myelofibrosis is that they have different goals. In ET, we try to mitigate their thrombotic risk, and in myelofibrosis, we try to mitigate their symptoms. For ET, we typically use hydroxyurea or the interferons, but for primary myelofibrosis, we typically use the JAK inhibitors. The patients at high risk for progression to acute leukemia does warrant a referral to the transplant team. Now, that's the basis for how we think about pre-fibrotic myelofibrosis. So it's key to understand those two diseases first. Now, pre-fibrotic myelofibrosis is a very interesting disease entity with a long-standing historical background where it's quite controversial. It stems back from the 1970s where overt myelofibrosis was first recognized, and potentially there was an entity with less fibrosis than overt myelofibrosis, but maybe this less fibrotic entity was a variant of chronic myeloid leukemia, or CML. We started to give names to this entity, prefibrotic myelofibrosis, and we first described it 20 years later in 1999 as an entity with the absence of any type of fibrosis. Formally, in 2001, by the World Health Organization, we started incorporating it as a stage within what we know as overt myelofibrosis. And similarly, in 2008, it was a provisional entity, again, within the domain of overt myelofibrosis. But in 2016 was kind of the groundbreaking moment where we've decided as an institution and as a group of researchers and clinical researchers that in 2016, it is a distinct entity by itself of prefibrotic myelofibrosis, distinctly different from overt myelofibrosis. And we continue to recognize that in 2022 with a number of diagnostic criteria. Now, it's very challenging. These patients with prefibrotic myelofibrosis may behave very similarly to the patients with essential thrombocythemia and very similarly to the patients with overt myelofibrosis. It's kind of this in-between. So in my clinic, I may see a patient with prefibrotic myelofibrosis, but it's hard to know because patients with ET and pre-PMF, they rely on similar clinical and laboratory abnormalities. Both of these conditions may be asymptomatic and may have elevated platelet counts. They both rely on the same driver mutations, including JAK2 or calreticulin or MPL, and the morphological analysis of the critical bone marrow biopsies rely on the same ideas, where key cells called the megakaryocytes are distinctly different, but to say how different they are is very subjective. I'm giving you an example on the right side here. This is what a hematopathologist would look at under a microscope for ET and a prefibrotic myelofibrosis patient. To me, as a clinical person, I really don't know the difference, and potentially only an expert hematopathologist could. I'm highlighting here how challenging it could be because they look the same. And finally, fibrosis grading, or the amount of scar tissue in the bone marrow, that is a little bit different between ET and pre-PMF, but it's quite subjective in saying how different they are between the two. The point here is that there's high intervals of variability in the literature, with consensus varying between experts at 49 to 100%, depending on which article you read, and at best concordance with MPN expert pathologists achieves only 88%. So there's a lot of room to improve in differentiating between ET and pre-PMF. Here are the diagnostic criteria for ET and pre-PMF, and though there are a lot of words, I just want to highlight the similarities between the two, and the fact that they both rely on looking at a single cell, megakaryocytes of importance, looking at the fibrosis grade, ruling out other conditions, looking at the same genetic markup of JAK2, calreticulin, and MPL, and maybe some nuanced differences. So it's really challenging to differentiate between ET and pre-PMF, but it really does matter. Similarly, differentiating pre-PMF from overt myelofibrosis can be challenging as well too. These patients may have splenomegaly and cytopenias, similarly to an overt myelofibrosis patient. But it's a little bit easier to differentiate between these two because the fibrosis grading is a little bit more obvious. The patients, I'll show you in a little bit there, but in studies, 4.2% of patients that were previously diagnosed with overt myelofibrosis could be reclassified as prefibrotic after really understanding the diagnostic criteria for prefibrotic myelofibrosis. and there's still low inter-observer reproducibility. So highlighted here is the grading of fibrosis by a bone marrow biopsy, and you can kind of get the intuition that these lines represent the scar tissue. MF0 and MF1 on the left side are the stages of lower fibrosis, and that's more indicative of early/pre-fibrotic myelofibrosis. And the areas on the right side are more burdensome for fibrotic areas, and those are indicative of overt myelofibrosis. Highlighting here is the diagnostic criteria, and here I'm really emphasizing that they're almost one-to-one identical, except for the fact that there is a difference in fibrosis grading. So moving forward, how do I treat prefibrotic myelofibrosis? Unfortunately, the clinical guidelines by the NCCN, the National Comprehensive Cancer Network, or the European Leukemia Network guidelines, they do not address prefibrotic myelofibrosis. And there are no clinical trials right now that have looked at prefibrotic myelofibrosis at all. There are some ongoing, and I'll talk about that, but we have no results to guide management. Taken together, there's no specific management paradigm for those with prefibrotic myelofibrosis. And my opinion and other expert consensus is that the paradigms borrow strategies from ET and from overt myelofibrosis. And that's why I discuss those two entities first. So here's my, So what do we know about prefibrotic myelofibrosis to guide our management? It's that it's in this in-between state. And we look at thrombosis, we look at symptoms, and we look at progression to overt myelofibrosis, leukemia, and survival. And we see in the middle of that prefibrotic myelofibrosis is between ET and PMF in all of these states. So there's still a high thrombotic risk, and there's higher rates for progression compared to ET in those with true prefibrotic myelofibrosis. But pre-PMF is still a little bit better than overt myelofibrosis in terms of overall survival. So given that it's in this in-between state, my opinion is that the management should be guided by both paradigms. So for me, patients with pre-PMF, they will look like ET patients. We do think about aspirin therapy to prevent cardiac events. And we do look at the risk for thrombosis and prescribe hydroxyurea or PEG interferon. And the goal there is ET-like, we try to prevent future thromboses. Similarly, at the same time, we look at if they're high risk for progression by looking at multiple risk stratification systems and readily refer them to the transplantation groups. If they're asymptomatic from a myelofibrosis standpoint, we observe them, or if they have symptomatic splenomegaly or constitutional symptoms, we do start a JAK inhibitor similarly to overt myelofibrosis. And the goals here are to mitigate the symptoms and theoretically prevent progression with transplantation. So I implement both strategies in parallel. Clinical takeaways, it's a controversial entity that's taken decades to recognize. The risks lie in between ET and PMF, and there are no treatment paradigms, though I look at ET and PMF strategies to treat my patients. But what are we looking at the future for the novel diagnostics and therapies in MPNs, or what I call JAK to the future? I want to give a plug for my own research. We've been developing artificial intelligence algorithms to automatically look at bone marrow biopsies to differentiate between prefibrotic MF and ET. And I'll just cut to the point. This is preliminary data. It's not published, so don't take this as word. It is not peer reviewed. But we were able to find that in our automated analysis of bone marrow biopsies, accuracy achieved even 90% in external cohorts, which is quite enticing. So there's further work to go. We're wrapping up the manuscript now, and we hope to get it out in the next few months. Moving forward about therapies, I talked about the pegylated forms of interferons, and I want to mention one specifically, rho-peg interferon alpha 2b, also known as the brand name BESREMi. There is a clinical trial ongoing in China under the PI Harry Nagel at the University of Hong Kong. Excellent work with a multi-center phase 2 study enrolling prefibrotic myelofibrosis and other myelofibrosis patients. And to my understanding, this was the first clinical trial looking at prefibrotic myelofibrosis. I'll talk a little bit about an ongoing effort with a lead PI of Gaif Abuzene at Cornell University. It's a phase 3 trial that hasn't yet started, but we will be involved. It'll involve 150 prefibrotic myelofibrosis patients, including low-risk asymptomatic overt myelofibrosis patients, and that'll be groundbreaking as well too. That's about to start. But just to give you a flavor about what to expect about ropeg interferon in prefibrotic myelofibrosis, this is the study from University of Hong Kong. They had great responses in terms of hemoglobin response, white blood cell response, and platelet response, as you can see here by this first column, achieving 70 to 90% in these domains at 12 weeks and 24 weeks. So that it somewhat normalized the blood counts, which is very helpful in prefibrotic MF. And even touching upon the disease modification idea, the burden of mutations of the JAK2 mutation was either stable or improved in 90%, and then 8% had achieved over half reduction in the JAK2 allele burden, also stemming to the idea that this could be a disease-modifying agent. So using this data of the phase 2 trial in the University of Hong Kong, we look forward to the HOPE PMF clinical trial that we're opening internationally, including in the United States, at multiple centers in the very, very near future this year. So that is it for today for prefibrotic myelofibrosis. Again, just to give a quick plug about OSU, we have a multidisciplinary group looking at myeloproliferative neoplasms specifically. At the diagnostic setup, we have a clinic that looks at cytoses and expedites the MPN workup. We have a group within benign hematology and the leukemia group that manages low and high risk myelofibrosis and other MPNs, including transplantation. Disease experts across all these ideas of diagnostic hematology, transplantation, hematopathology, and our leukemia group, and a number of novel therapeutic trials that we are excited to offer our patients, including those with prefibrotic myelofibrosis here in the upper right-hand corner. And that's it, and I'm happy to take any questions. So thank you so much.
Let's see, where are we here? That was fantastic. If you can take your slide off the screen, I think there we
Yes.
are. Okay, great. I have so many questions, and some from myself and some from other patients, but I'm going to ask from the patient side. This person was diagnosed 2 years ago with JAK2 and PV following a DVT. In 2025, they were diagnosed as transitioning to MF with fibrosis 1 to 2 on a scale of 3 and taking Jakafi, and the white blood counts are now normal. Can they expect this normalization to continue, or should they expect a fibrotic breakout at some point?
That is a great question.
Yeah.
I will caveat that I will defer final decision making for medical decisions to the treating provider,
Yes.
but I'm happy to give some of my thought process about that. It is not uncommon to see polycythemia vera patients progress to this seems like more overt myelofibrosis with MF2, and ruxolitinib is a very common JAK inhibitor to use. What we see is that ruxolitinib is excellent for achieving cytopenias as a side effect, quote unquote, of ruxolitinib, but it could be a beneficial aspect for those that have cytoses, like this patient with an elevated white blood cell count. I do expect that we will see prolonged responses, though I do not think that ruxolitinib is a curative therapy. So it's unknown to me if they will achieve permanent response of the white blood cells from the ruxolitinib. Thankfully, though, if the patient quote unquote relapses after ruxolitinib, there are so many other therapies that are options now in 2025, including 3 other JAK inhibitors that have been explored in the space where ruxolitinib no longer works, as well as clinical trials. And we're looking at many clinical trials. So there's more to come. Whether or not, the second question of will I expect fibrosis to continue, I think that's hard to predict. There are some patients that achieve some response in terms of reversing fibrosis with the JAK inhibitors. That's not a guarantee by any mean, and it's also not a guarantee for the fibrosis to worsen. So it's really hard to know, and I think that there's a lot of ongoing interest in predicting who progresses and who improves. in terms of fibrosis, and we're just not there yet in 2025.
Yeah, yeah. I mean, it's so disheartening with all the research that is being done and research in progression. The MPN Research Foundation is trying to jump after that, which, I think everybody is looking at that, but hopefully their efforts will come to some conclusion or juncture where we can say, yes, this patient, because of their genetic makeup and because of, previous episodes or whatever, they will be able to determine if that person is going to progress, and then to find something to halt that would be the optimal thing.
Yes, completely agree.
Yeah. Does having a JAK2 mutation and a DNMT, I'm not sure what this is, 3A mutation increase the risk of progression to AML or MF? Can anything but be done to prevent that? We were just kind of talking about that.
Yeah, so that's a great question as well too. DNMT3A is a very common mutation associated with myeloid neoplasms, or colloquially blood cancers within this realm of cells called myeloid cells, and myeloproliferative neoplasms is one of them. We do have risk stratification systems to predict a little bit better about who progresses from myelofibrosis to acute leukemia. And one of the more modern risk stratification systems is called MIPS, MIPPS, MIPS 70 version 2.0. That's the one that I use in my clinic. And they do specifically highlight the mutational profile of those that are higher risk compared to not. And I will say DNMT3A is not one of those in the MIPS 70v2 stratifications that is a high risk mutation. So that's one that I will follow, but that's not one that gives me nightmares at night, if that makes sense.
Mhm. So, there are several questions here. There are differing opinions. I've been around in the MPN space for a long time, and there are still differing opinions about when to treat and what to treat with. And so, just your opinion. I'm a new patient that comes into your office. You see me, and I have ET, because we know now that more women are being diagnosed with ET. And the only symptoms I really have are, you can see it in my blood, but I also have some symptoms around menses, some symptoms around menopause, or whatever the specific female things are. Do you treat me, or do you say, let's watch and wait? You're not suffering horribly. These are normal things, or, what is your strategy?
Yeah, so I think that every patient is very individual, and though I have some treatment paradigms, what grounds a lot of my decision making is patient desire and patient autonomy. So I tend to offer treatments, but I also want to listen to what the patient has to say and what their priorities are. So for an ET patient that you describe, first I would do risk stratification to see if they're very low, intermediate, or high risk for acquiring a blood clot. Most of my patients do get aspirin. And then if they are higher risk for acquiring a blood clot based off of their clinical and genetic makeup, I would offer cytoreductive therapy with either hydroxyurea or one of the forms of pegylated interferons. And in my practice, I use either pretty frequently, although I do know that there is quite a lot of controversy about either one of those agents. I'm of the mindset that they're both effective in very different ways. I tend to say that my patients that are younger, I offer interferons more so than hydroxyurea. In patients that are older, I tend to offer hydroxyurea than interferons. I don't have a specific cutoff of what that age is. So, patients that are at menopause, I don't have a cutoff. So I'll talk to them about both. I'll talk about the side effect profile that the interferons tend to have a little bit more than hydroxyurea. But I also would talk about the potential disease modifying effects of interferon and trying to weigh, that decision making for the patient perspective. And then give them that shot if they do want an agent that has been shown to reduce the JAK2 frequency and potentially be disease modifying. I would favor peginterferon. But for patients that have difficulty affording things, or their insurance is not very good about copays, and they really don't want to deal with injections or side effects, I have no qualms offering hydroxyurea. So it's not a one size fits all, but that's my general paradigm for ET.
And so the follow-up question too, actually, well, one I can speak to from experience, and that is the companies that do make our products and our drugs are willing to help patients get drug, you know, if their insurance doesn't cover it and so on. But also, so during pregnancy, can you clarify? I mean, if I am a person, again, your patient, and I want to get pregnant, I don't think you can continue the hydroxyurea, but you can the interferon. Is that correct?
Correct, correct. So pregnancy is a very tricky episode that needs to be managed very, very astutely. Hydroxyurea is teratogenic and has black box warning for those that are pregnant. So I definitely do not prescribe hydroxyurea, and that is another part of my decision making. The younger patients that may intentionally or unintentionally become pregnant, I really don't want hydroxyurea to be in that domain. So I tend to prescribe interferons because of that.
Right.
So interferons I typically use, but if there are side effect profiles or interferons that the patients still don't abide by, there is the realistic strategy of just watch and wait
Yeah.
and platelet if we really need to, although I hesitate to do that.
Yeah. Is there any documentation on the patients who have reversed the fibrosis?
Yes, there is documentation of that. I do believe I'll have to look at the JAK inhibitors. I do believe there are JAK inhibitors, but now that I am a PI of a number of novel therapeutic clinical trials, reversing fibrosis is actually a very hot topic where there is preliminary data from a number of these novel agents, not published yet, but has been presented at a number of our national conferences where these patients have reversed their fibrosis. And though that's not the endpoint of the clinical trial, that is what I talk about in clinic because I do think that patients really like to hear some of those side ideas that potentially these agents could be disease modifying, and fibrosis is one of those.
We know that a lot of drugs now are being used together. So like Jakafi with interferon or something like that. And the question is Jakafi not effective at reducing symptoms of diagnosis of pre-MF? Is adding an interferon a reasonable approach?
So I think of symptom management in prefibrotic myelofibrosis very similar to symptom management in overt myelofibrosis because theoretically these two diseases are on the spectrum of one another, and that the underlying biology behind both these diseases are similar. So the concepts of how we treat overt myelofibrosis and the reasons for them working, I do extrapolate to prefibrotic. So I do expect a reduction in the symptom scores and the patient experience with ruxolitinib and the JAK inhibitors in prefibrotic myelofibrosis. So it's not that I expect them to not work. I do expect them to work in prefibrotic myelofibrosis. The idea of combination therapy in all of these diseases and MPNs is a very hot topic. There are a number of investigator-initiated clinical trials looking at interferon plus ruxolitinib. I do believe in Europe they have this ongoing, but in general, the idea of combination trials with ruxolitinib plus a novel therapy, we have ruxolitinib plus BET inhibitors. We have ruxolitinib plus selinexor, but there are so many novel clinical trials looking at combinations. Which combination to prescribe or think about is truly unknown. But I do think in clinical practice, we do see some providers do combinations when they're not getting sufficient response from one alone. Alternatively, you could think about switching agents.
Mhm. This person is 75 years old with PV, diagnosed in 2018 and currently taking hydroxyurea. Their blood counts are currently controlled. Would you recommend switching to BESREMi with the hope of slowing progression? Or do you think the increased side effects possibly aren't worth it at this age? Great question.
That's a great question. And I don't think that there's an answer there. but I will offer some principles that may guide to a mutual answer that's decided between that patient and the provider. I do think that hydroxyurea is very reasonable for a 78-year-old with polycythemia vera, where everything is controlled. There's no disease symptoms that are reducing the patient's quality of life, and there are no new symptoms from the side effect profile of hydroxyurea that are reducing the patient's quality of life. So I do think that hydroxyurea is very, very reasonable. When I talk about interferons, the chance of disease modification, it's on the scale of years to even decades. So, we've been looking at some new research, particularly, I think it was the Danish group that was looking at very young ET and PV patients, less than 25 years old, that were prescribed hydroxyurea versus interferons. And they showed that the patients that were prescribed interferons progressed to myelofibrosis less frequently. But the time scale of that research study was on the order of decades. So the research study that I mentioned, there are a lot of caveats. Number one, it wasn't a randomized clinical trial. Number two, it was retrospective. And number three, with the nature of retrospective data, it could have rife with biases. We don't know. But that's just what we observe, that we may see signals of disease modification. But realistically, in my belief, it would be on the order of decades. So if this was my patient, I would offer that information that if you were looking at disease modification, it would be on the order of decades, and try to say, what is our mutual priority here?
Mhm. Very good answer. This is about an ET patient with CALR deletion mutation. A
Mhm.
bone marrow biopsy several years ago had reticulin fibrosis score of 2, but no collagen fibrosis. The hematologist said that reticulin fibrosis is not as concerning for progression. Can you explain the difference regarding progression to MF between these fibrosis factors?
That's a great question. And I can't speak to exactly what the previous physician had mentioned to the patient. All I can really say is that the diagnostic criteria for overt myelofibrosis, or, I'm sorry, did this patient have a previous MPN? Was it ET or PV?
ET.
ET.
Uh-huh.
So post-ET myelofibrosis, the diagnostic criteria does say that a reticulin fibrosis of grade 2 or 3 is sufficient burden of fibrosis for progression to overt myelofibrosis.
Mhm.
So if this patient, that's one of the major criteria. If the patient met the rest of the major and minor criteria, then this patient would meet criteria for progression to myelofibrosis. So that's all I feel comfortable saying about that situation.
Okay, okay. Um, are you seeing, what are you seeing in terms of, I remember when I first got into the MPN world, there were many more men that would raise their hands with PV. And there were many more women now with ET that raise their hands. Are you seeing the numbers climb or decline with MF? And I mean, we have these 4 new drugs approved by the FDA and so many more in the pipeline. And we understand the diseases better, I believe, after these many years. The JAK2 mutation was discovered in 2004 or 5, and now we have all these gene mutations that we're looking at. What is your opinion about that? Or what do
Uh,
you know? What do we know?
about gender disparity?
About gender, but also about numbers, are the number of patients progressing, is that declining or growing exponentially, or is there any?
Yeah, great questions. I will have to get back to you on that about the specifics. I know that there's been a lot of research about gender and MPNs, and I don't have that answer off the top of my head. But
That's
I will tell you anecdotally, that's not something that I've recognized. I treat both male and female patients. I don't even think about it, honestly, because I do have a large number of both male, female in PV, ET, and myelofibrosis. I don't mean to say that I treat them the same. There are very
right.
specific, issues, particularly with women in MPNs that are more prevalent than men in MPNs. So I'm very cognizant of that. But I don't necessarily appreciate a drastic difference in terms of the sheer volume that I see. In terms of the epidemiology across MPNs as a function of time, I'll have to take a look. I don't know the answer to that, but I will say that my guess is that we are seeing an increase in these diseases. I'm guessing. And the reason why I'm guessing is because of this idea called CHIP, clonal
Yeah.
hematopoiesis of indeterminate potential. And
Yes.
what I mean to say is that potentially the diseases are not more prevalent than before, but we're getting way better at diagnosing them.
Yes.
Technology is better and better. We're detecting them earlier and earlier, where we're seeing these mutations such as JAK2, calreticulin, MPL without even obvious manifestations like high blood counts. And that's an entity called CHIP, clonal hematopoiesis of indeterminate potential. And in my opinion, that's kind of on the spectrum
Yeah.
of very, very early MPNs. So I think we're just getting better at detecting these. And anecdotally, I will say, I have a number of very young,
Yeah.
less than 25-year-old ET and PV patients. And I do think it's because of this idea that we're just excellent at finding these patients now.
I would agree. And, we started a program for pediatric and young adults with MPNs. In fact, we have a program on Thursday with the mothers, two mothers of patients that were diagnosed when they were very young, and they're still young. They're young adults now, but what the impact is on families, what the impact is on the children, and so on. And it's very real and very interesting. So join
That's
us if
great.
anyone is listening.
Yeah, I'll refer my
Here.
patients to
Yeah.
that program. That's great.
Yeah, and I think you're right. I think, what I'm hearing from mothers is the pediatricians are now, doing CBCs with the children at an earlier, as soon as they start to see them. And we're also having Dr. Nicole Cousin, who's a pediatric MPN specialist in New York. She'll be speaking at our New York event about the transition from youth to adulthood with an MPN, which I think is a very, very important discussion. Okay.
Yes.
I have a couple more questions here. I was re-diagnosed from ET to pre-PMF with the MPL mutation, currently taking Pegasys, and want to know if BESREMi is superior to Pegasys. Could I join the HOPE clinical trial, or is the recruitment closed?
Great questions.
Yeah.
So I think Pegasus versus BESREMi is a very hot topic as well too. I think that there is a lot of conversations to say that they're different agents, but operationally, I know a lot of providers treat them very similarly, and then try to find operational benefits such as cost to choose one versus the other. So until we have side-by-side data in a clinical trial, or at least observational data comparing Pegasus versus BESREMi, we don't know which one is similar. I'm sorry, which one is superior right now. We have more data for Pegasus because it's an older agent, but I think BESREMi, we are still interested to kind of figure this question out. In terms of, are you eligible for the HOPE PMF trial? The HOPE PMF trial is not open. So it will be open soon. We are working on opening it, and I know that a number of other centers are working on opening it. As far as I understand, no patients have been enrolled in it just yet, so there's still opportunity. I'm concerned, though, that I do believe that one of the exclusion criteria for the HOPE PMF trial is having prior interferons, such as Pegasus. I will have to double check. So keep your eyes open and ears. I'm sorry. I think it's both
On the
eyes and ears
ground.
open. Yeah. You'll have to take a look at the details, but I think
Yeah.
that prior interferons might be an issue.
And we will keep that information out there, or get that information out there. It's funny because I was part of a team that went to Roche to get them to let us have Pegasus all those years ago for our MPN patients. And the good news is BESREMi is for MPN patients, and Pegasus was not created for MPN patients. So
Right.
let's hope that it does come above, Pegasus, but in the meantime, other people are, everybody's doing well on everything mostly. And so it's a good thing that we have options. Are there any studies or examples of people who have been able to get their bone marrow to return to blood production to take the pressure off the spleen?
Yeah, so I think this is very similar to the prior
Yeah,
question. What this patient is asking is kind of how do we get back to normal? And the other question was how do we reverse fibrosis? And I think that's kind of the same question,
yeah.
because the issue with MPNs is that there's a lot of fibrotic tissue. There is some anecdotal evidence that some of these agents can reverse fibrosis and implement what we call a complete pathologic response. Hydroxyurea actually has been shown to induce complete pathologic response based off of the MPN Research Consortium 111 and 112 trials, the ones that were looking at hydroxyurea versus Pegasus. It's not consistent across every single patient, but I do think that there's anecdotal evidence that there are patients that respond very, very well to a number of these agents. And
Mhm.
as I mentioned before, the clinical trials that are upcoming, almost all of them are looking at this concept of reversing fibrosis and recovering bone marrow production with hemoglobin response, platelet response, white blood cell response. So they are looking at this. Yes.
Mhm. Is anyone looking at, currently, if you have MF and you're starting to have issues, you have an option of having a bone marrow or stem cell transplant. And, there are lots of success stories out there that were not there when I first got into this field. And do you think the day will ever come where a patient who's suffering quite a bit with PV would be able to have that option?
Have the option of transplant?
Yes.
I think it's hard to say.
Yeah.
I think realistically, the answer, as we know, transplantation in 2025 is no.
Yeah.
I think that in my patients with polycythemia vera, that I worry a lot about progression, such as, I have some patients with TP53 mutations, polycythemia vera. And for those of you that may know about this mutation, it's not a good mutation, and ones that portends to higher rates of progression to leukemia when you have myelofibrosis. So when I have a PV patient with TP53, I worry about the same thing as could this
Yeah.
patient progress to leukemia very quickly? I refer to the transplantation group to say, we got to transplant them while they're in the polycythemia vera phase. And they say, logistically, with insurance, PV is not an indication for transplantation right now. The risks outweigh the benefits when they're in the PV phase. So the patients must show that they're clinical burden and they're on their way to progressive leukemia before that balance of risk benefit really favors transplantation. That's in 2025. Now, in the future, can we revisit that conversation to say that transplantation strategies have improved so much that we can offer these these curative therapies to patients in earlier phases? I think it's a very real question. And
I know two people off the top of my head that were patients with PV and it could not do anything until they progressed to AML. And of course, it was too late. They both
right.
were transplanted and they both did not live more than 2 weeks.
And
And
that's terrible to hear.
yeah, it's a horrible thing. Yeah.
Yeah. I think that big picture, what we should be looking at is these non-transplant therapies that could be really disease modifying and potentially curative.
Yeah.
I know that there are a number of agents that I'm really excited about in early phase clinical trials that could be potentially disease modifying. They're not looking for a cure in 2025, but if they're working very, very well, we may be seeing a cure in the next few
Right.
decades.
And that was my last question to you before we hear from three of our industry partners. And that is, what hope would you impart in words of enlightenment to our patients? I'm always the optimist about what's coming in the pipeline and what's out there and all the incredible researchers, including yourself, who are doing fantastic work in this field. I've just never seen anything like it. And so what wisdom would you impart to our patients and caregivers today?
Yeah, I would say that though right now in clinical practice, there's a lot of reservations in terms of what we can do and offer. I will say that this is a very exciting time and honestly a golden era for novel therapies in advanced MPN such as myelofibrosis and including, PV and prefibrotic myelofibrosis. There hasn't been this many clinical trials, I don't think, in history
I
for
don't
these
either.
diseases.
Hmm.
And similarly, the scientific community, it's a small community and it's, very tight knit. We all know each other very well and we're all aiming to do the same thing and really getting down to that myelofibrosis and MPN stem cell and getting rid of it and delaying progression to acute leukemia. We're doing it in a number of multifaceted, multidisciplinary ways. Myself exploring, the use of artificial intelligence. That's kind of my niche and what I can offer. But I have a number of collaborators in the laboratory, exploring mechanisms of disease, exploring mechanisms of resistance, and identifying novel therapeutics. So I'm very busy, and that's a very good thing. It's very exciting to be in the research domain of MPNs, and I hope that we can translate that to patients in the near future. And I really do think that we will.
Yeah, I'm very optimistic about that as well. And I thank you so very, very much for being with us today. I know you're really busy getting back from taking care of your wife and baby and your new little girl, and enjoy her. And we will be in touch. And thank you again for joining us today.
Great. Thank you so much for the invitation. Have a great day, everybody.
We'll be in touch.
Great. Goodbye.
Excuse me. So we'll move on. And our first industry partner, who's been a partner for many years, is Insight, and Kristen Griffiths, who's the Associate Director of Communications and Patient Advocacy, is with us. Hi, Kristen. Can't hear you. Excuse me.
So sorry about that. Thank you.
There you go. Hi, welcome.
Thanks for having me. So I'm really happy to be here. I appreciate the time. My name, as Man mentioned, my name is Kristen Griffiths, and my role as the Associate Director of Communications and Patient Advocacy at Insight is really to lead programs and partner on initiatives at Insight that support the MPN community, including raising awareness of these rare cancers, sharing real patient stories and developing important tools to aid the patients in their experiences. So I'm really happy to be here today. So thank you to Anne, Natalie, Mallory, and the whole team for letting me be here and talk a little bit about Insight in our company and its commitment to patients. So if you haven't heard of Insight, we are a global biopharmaceutical company headquartered in Wilmington, Delaware, but our mission is to solve on. And what that means to us is really how we relentlessly follow the science to find solutions and tools for patients with critical unmet needs, regardless of the disease size or patient population. And by partnering with groups like Anne's, we're better able to understand the needs of the healthcare providers, of the patient communities, and in turn, this helps us inform how we advance the science and support communities that we serve. So a couple of things that I heard all of you ask about today that I wanted to talk about. One, most importantly, is access. So making sure patients have access to our treatments prescribed by their healthcare professionals is really, really important to us. Our patient support program is called Insight Cares, and it offers insurance verification, prior authorization support, help with financial assistance, and other programs for eligible patients, treatment or condition education, and we can help locate appropriate support resources if you need them. So we always recommend you enroll, even if you don't need it now, because circumstances can change, and this really can help us get you support more quickly. So if you're interested, that's insightcares.com. We spell it INCYTE cares.com. Clinical trials, another thing that we had talked about today, and for us, we feel like to solve on, we must pursue the science. And we believe the power in research to advance scientific innovation and improve patient health. We are currently recruiting for clinical trials. We have all of our information for the clinical trials that we're recruiting for on our website, insightclinicaltrials.com. I know you can find it other places. Ours are the most up to date on our website, so highly recommend you check that out if you're interested in looking into clinical trials, and you can talk to your healthcare provider about considering one. And then the last thing I just wanted to mention today is really just about community support. Obviously, this is a wonderful community and there's so much value here. Another option for you is a website that we created called The Unseen Journey. And this is really, it was created to highlight stories of people living with MPNs. And we're utilizing generative AI to really create beautiful imagery and help raise awareness of the symptoms that are often unseen and not understood by others that so many of the MPN patients face. So if you're interested, I highly recommend that you check out that website. We're actually recruiting for other patients to be involved and potentially have their stories shared on the website. So please reach out to us if you're at all interested. And can put you in touch with us if you need to, but just wanted to highlight that. And we also have the website, Voices of MPN. Hopefully you've heard of that before, with a lot of great information, symptom trackers, symptom assessment forms with Dr. Mascarenas, lots of great tools there for you too. So I'll close it there. Thank you guys so much for having me. I love discussing our passion and our work, and please reach out if you would like to know more. Thank you.
Thank you very much. And we appreciate it, Kristen. And we're doing a series on patient stories, but with themes, and it's been really wonderful. I mean, this week we started, and yes, every time a patient hears from another patient is a great thing, that they can get insight and sometimes direction from the other patients. So thank you very much. And we'll move on to Sobi and Leslie Ferber, who's the Associate Director of Patient Advocacy. Hello, Leslie.
Hello, it's been a while.
Yes.
Thank you, Anne and Mallory and Natalie, to really put on an amazing program. I always say there's such a value in, having everyone together and just kind of nodding along to the same thing, because you don't have to explain much, right? Like, everyone knows exactly what you're going through. So thank you for, hosting this space. So as Anne mentioned, my name is Leslie Ferber, and I'm the Sobi advocacy lead for the MPNs. Sobi is a biopharmaceutical company, and their mission is to make innovative care, such as treating people with rare and severe diseases such as MF possible. As I think you've heard throughout the whole talk, there's been a lot of advancement in the understanding of the biology of myelofibrosis, and really, you have the science, and then you really have the human piece, right? Just having people to really connect with. So to further and learn and understand, we work with a lot of the advocacy groups, such as MPN Advocacy and Education International, and to really understand how to really empower folks. And so some of the things that we identify, which I feel like you all are doing fantastic on, is really elevating the voice, right? Evolving in the evolving understanding of the biology and the disease and the treatment, empowering patient living with MF and the caregiver to really have that conversation, on your symptoms, on your counts, on honestly anything that's on your mind that is, affecting your treatment plan, and providing support for groups to work together and just really bring that unified platform, so you all can have that dialogue and support. The other thing that I thank you, Kristen, for saying too is, it is so important. Like, access is always a huge part, right? What's the point of having a treatment if you can't actually have access to it? So, the therapy that we have is that we have one of the JAK inhibitors, and it's called Vonjo or pacritinib. And, you can always go on to our patient access program or assistance program is called Vonjo Connect. So, it is always important for you to kind of just know what your options are and how to kind of have access, because we know life change. And so on that note, thank you, Anne, for having us as always. And have a wonderful morning or afternoon, depending on where you are.
Thank you very much, Leslie. And our last partner that's joining us today is Sima Bhatt, who's the Executive Medical Director at DISC. And please welcome Sima.
Thank you so much, Anne. This has been a wonderful session. As Anne said, my name is Seema Bhatt. I am the Executive Medical Director at DISC Medicine. And on behalf of DISC, we'd like to introduce the RALLY MF clinical trial that is currently enrolling patients. It is a phase 2 trial that's open to patients with primary or secondary myelofibrosis that have anemia. And that means their hemoglobin is less than 10 grams per deciliter, or they're requiring transfusions. Patients may be enrolled regardless of whether they're on another MF-directed therapy like JAK inhibitors that have been discussed today. DISC-0974 is an investigational monoclonal antibody that has a potential to reduce a protein called hepcidin that is abnormally high in patients with inflammatory conditions like myelofibrosis and can be used to treat the anemia. So the goal of the study is to understand if treatment with DISC-0974 can improve anemia and reduce transfusions. And then, of course, the study will also be collecting information regarding the safety of DISC-0974 and any side effects or risks to better understand how improvement of anemia can also improve the way that patients with myelofibrosis may feel and function. The drug is administered as a subcutaneous shot monthly for 6 doses. And patients who do have a benefit after that initial treatment period have the option to continue treatment for a longer period of time. The trial is now enrolling at many sites across the country. And if you're interested, you are welcome to reach out to us for more information. And the best email address to use is clinicaltrials@discmedicine.com, and DISC is DISC. We also are listed on clinicaltrials.gov if you'd like to gather more information. And really, thank you for allowing us to be here. We really appreciate it.
Seema, thank you very much. We're really looking forward to watching the progression of your drug and to see how it will help MPN patients. So we really appreciate it, and we appreciate the partnership. Thank you very much. So with that, I just want to remind everyone that tomorrow we have a webinar with 2 women who have an MPN who are going to discuss going through menopause and some other things that changed their lives in some ways and how they navigated with their MPN. And then on Thursday, we'll hear from 2 moms who had children who have an MPN, what that was like for them, their families, the child that actually was diagnosed. Really good stuff, good information, and good stories to hear if you are a mom out there or dad who has a child with an MPN. If your child has already grown and gone on to bigger and better things, but also if you're female and you're just now navigating through these times with an MPN, join us. And we have many more coming up. Thank you so much for today and for joining us today.